World AIDS Day this year finds us deep in the throes of another pandemic, COVID-19. The highly infectious novel coronavirus has swept across the world, devastating health systems and causing economic turmoil. Not since the HIV/AIDS pandemic of the 1990s have countries faced such a common health threat. Around 33 million people worldwide have died from AIDS-related illnesses in the last 40 years. It's taken expertise, collaboration and dedication from all levels of society to track, understand, treat and prevent the illness. Although HIV/AIDS hasn't been eradicated, the global response is an example of what can be achieved when countries and people work together.
This is DW's COVID-19 special. I'm Kate Ferguson. Thanks for joining me. Once upon a time, an HIV diagnosis was seen as a death sentence. Those days are now gone, with advances in treatment allowing people to live long and rich lives. But challenges do remain, especially amid a global pandemic that's seen the supply of HIV drugs in some parts of the world severely disrupted. Around the world, there are some 38 million people living with HIV. Last year alone, some 1.7 million new infections were recorded and 690,000 people lost their lives to the disease. People living with HIV are especially vulnerable during this pandemic. For one, they're more at risk of falling severely ill with COVID-19, but perhaps even more crucially, as the coronavirus shuts economies down, many sufferers have not been able to access medication.
It's a very welcome arrival. Employees of the North Star Alliance deliver HIV drugs to the Gondwana settlement west of Johannesburg. The risk of becoming seriously or even fatally ill with COVID-19 is twice as high for HIV-positive people. Many are avoiding overcrowded hospitals for fear of infection. However, interrupting treatment can have serious consequences. UNAIDS expects up to 148,000 additional HIV deaths related to the coronavirus pandemic by 2022, especially in poor regions. The greatest number of people with HIV live in Africa. More than 25 million in sub-Saharan Africa, twice the rest of the world put together. Sibongile Zulu is a single mother of 4 children in Johannesburg. Her clinic ran out of drugs during the hard lockdown in the spring. On top of this, the 47-year-old lost her job. For 2 months, she had to do without half the medicine she needs. She's now receiving support from a Christian aid organisation. North Star Alliance is trying to get close to the needs of the most vulnerable people using mobile clinics. This kind of assistance helps save many lives. But the World Health Organization says more is needed. More financial aid, but also the commitment that the battle against HIV/AIDS is fought with the same determination as the fight against the coronavirus pandemic.
Let's speak to Professor Jürgen Rockström, President of the European AIDS Clinical Society. He's joining us today from Bonn. Professor Rockström, welcome along. How disruptive has the COVID-19 pandemic been for people living with HIV/AIDS?
Yes, I think it's very different from country to country. There have been surveys in various parts of Europe suggesting that at least 50% of the physicians who are involved in HIV care also manage the COVID patients. So obviously they have 2 diseases to serve, and as such there have been disruptions. In our own clinic, we closed the clinic for 2 months in April and May and just sent out prescriptions. I think the biggest challenge has been for testing services because of the issue you can't go and have contact other people, and so in the lockdown a lot of people were not able to assess the usual testing frequency, and that's one of the big worries around missing HIV diagnosis, because people cannot go to the adequate testing services.
And how dangerous is COVID-19 itself for HIV patients?
Yeah, so that has been an ongoing discussion, because obviously people with HIV have often immune deficiency depending on their level of CD4 count. and as such may be at an increased risk for any kind of infection. And so there was some worry that they may have a different course of disease. The first case reports, though, from North America, China, and Europe suggested that really the outcome was very similar. So it doesn't really look as if the mortality was enhanced or increased. There has been a more recent, larger cohort analysis, and I think that's one of the issues. If you only look at small patient numbers, you may miss something because the patients on average were much younger than some of the patients who had a more unfavorable disease outcome. And in Africa, there was a 2.6-fold higher mortality. There also has been a higher mortality reported for HIV patients from the UK, around 1.6-fold higher. So I think in summary, it looks as if in general, it's pretty much the same outcome. But if you have a low CD4 count below 200 and you're severely immune compromised, I think that's where you may have a more increased risk. But overall, mortality is low. And I can say from my own clinic, we've seen 10 patients with COVID-19 and HIV, and none of them was admitted to intensive care. None of them died. So I think in general, in the younger patient population, not so worrisome, but if you are older with comorbidities and as an HIV patient, you have a higher risk for comorbidities, then I think there is a somewhat increased risk.
Okay. Now, we're very close to having several vaccines against COVID-19. Why is there still no vaccine against HIV?
Yeah, so 2020 was unfortunately a year where a vaccine which had showed some promise in the Thai vaccine trial where there was a 33% reduction in new infections, and now this improved vaccine was tested in South Africa, and unfortunately the trial was stopped because of lack of efficacy. And I think the reasons is that HIV employs the shield technology, and the virus is constantly changing its shield to protect itself. And these changes sort of evade a vaccine attempt. So it's not so easy to target HIV. And that's a little different than some of the other viruses which have less changes in their surface.
So the United Nations has set itself the goal of ending the AIDS epidemic by 2030. Do you think that's realistic?
Well, on a more positive side, if you look at some of the recent numbers from the UK, you can see that actually they're very close to ending the epidemic because they have more than 95% of their patients are diagnosed who have HIV, at least in the London region. They have more than 95% on treatment, and they have more than 95% virologically suppressed. So they're doing very well. And the new numbers are falling really quite dramatically. And it's really great to see that with the tools we have to end the epidemic, if you can use them, that's all working very well. But if you turn your eyes a little bit to the east and you move to Russia, for example, which obviously has a much higher patient burden with over 800,000 infected individuals and only probably around 55% receiving antiviral therapy, there remains a large pool of people who are either not diagnosed or replicating and can as such infect other patients. So the question is, how can we get all these tools we have implemented everywhere in the world? And obviously also now in the COVID epidemic, where there's suddenly a struggle for resources from one side to the other, physicians are engaged in services for two diseases at the same time. The disruption of services on many different layers, stock out of ARV happening in many African countries, will obviously put a big hazard to the goals which have been set up and the accomplishments, although theoretically, at least there are good examples in clinical practice where these goals seem reachable.
So some hope there. Jürgen Rockström, President of the European AIDS Clinical Society, thank you very much.
Pleasure.
Time now to answer one of your questions about COVID-19. Over to our science correspondent, Derek Williams.
What makes SARS-CoV-2 different from the SARS virus? Is it the same pathogen, just stronger?
No, although this common question shows how much power there is in a name. The international body that's responsible for naming newly discovered viruses decided to call the one that causes COVID-19 SARS-CoV-2 because it's fairly closely related to the one that caused the respiratory disease SARS back in the early 2000s. But although there are similarities in some of the symptoms that the two pathogens cause, they're not the same, and SARS-CoV-2 did not arise from the virus that causes SARS. A genetic analysis has placed both in a group of what are called lineage B beta coronaviruses, which also includes a number of other coronaviruses that are found in bats. A major characteristic that beta coronaviruses share is that they infect mammals, which means they exploit the similarities that all mammal cells have in common to invade them and make more copies of virus. And sometimes they jump from species to species. The three beta coronaviruses that have jumped to humans to cause recent outbreaks, the pathogens that are responsible for SARS and MERS and COVID-19, they've all caused respiratory symptoms and fevers, but in other ways, like the timing of the disease that they induce and its overall lethality, that differs widely. SARS was much more deadly than COVID-19, for example, but because people who got it only began infecting others after they started showing symptoms themselves, it could be contained more easily. SARS-CoV-2 is not stronger than the virus that caused SARS, and it's not the same. It's just a cousin that's turned out to be a lot better at spreading in human populations. And though it can also be deadly, if you catch it, COVID-19 is actually a lot less likely to kill you than SARS was.